Hi everyone, thank you for coming. We're just going to wait a few minutes to let people join because there's a stream of you all coming in now, and we'll get started at about 5 past. Okay, so we'll make a bit of a start now for those of you who are still joining. Welcome for those of you being here before. Welcome to our PSA series, the fourth in the series, which will be covering adverse drug reactions and prescribing today. Just a little bit about how this session will work if you've not sort of come to one before. We are a group of F1 doctors in the Northwest Deanery. It was set up to aim to sort of facilitate your revision prep for starting finals, and now we've kind of expanded that into some wider areas. So this year is the first year of our PSA series. We're looking to do some other things in the summer, such as OSCE days, and some help with things like the SFP, that'll be useful to share with sort of your peers and years below. So the plan for sort of the year so far is that this is the fourth of our 5th PSA sessions in January. The next one and final one is next Tuesday. All of these have been focusing on different areas of the PSA. We also have a final series, which is every Thursday. That'll be being done by our lovely Katie, who's also doing tonight's session. So she's doing 2 in a week, which is very kind of her. It's on neurology this week, covering headaches, and it's sort of a different topic from finals each week. The format is going to be lots of timed questions. So we're going to treat this as we're going to give you a bit of an overview about the sections of the PSA we're covering today, and then do a mock exam style with 9 questions, where we'll give you about 2 minutes per question, which is reflective of sort of how long you'd probably spend on it in the PSA. And then we'll talk you through the answers and some explanations. For the sake of session flow and things running a bit easier, there's a Q&A box that you can pop any questions in throughout the session. We're going to answer these at the end, just so that any questions that we may answer in the duration of the session have been covered. So any questions, pop them in the Q&A box.
So if you've been to this session before, you'll have probably seen this slide already. It's just a quick recap of how the PSA works. So it's an 8-section exam that lasts 2 hours. I think the trickiest part is really the time pressure. So yeah, good time management is really key to doing well in this exam, which is why we're kind of setting the session up how we have, so giving you 2 minutes per question. So try and stick to it if you can. Yeah, efficient use of the BNF is very important. If you don't know something, because it's an online exam, you can flag it for later and you can come back to it, just to kind of keep that time management good. There are practice papers on the PSA website, and QuesMed also has a lot of good questions and mock papers. If you haven't used that already, it's something I'd recommend. Just having a quick look on the PSA website, the domains that this exam covers are obviously just things like medicine, surgery, elderly care, peds, psych, obs and gynae, and GP. So very broad topics.
So today we're going to be covering 2 of the sections in the PSA. We also did another prescribing session on the first week, but we're giving you a bit of a recap on this because this is the biggest section. So it's 10 marks per question, total of 80 marks out of 200. So it's 40%. So it's the one you want to be sort of putting the most of your time into and giving yourself the most time to find the answers. It's 8 questions. You score 5 marks for giving the correct drug name. If you do get the incorrect drug name, you can still get the preceding 5 marks for giving the correct dose, route, and frequency. So all's not lost if you've got the wrong drug. You can still pick up half of the marks for correct prescribing. Remember to, especially things like frequency, things like antibiotics need a duration as well. So we don't want to be just starting a course of antibiotics with no finish date. So double check the duration. Often it's sort of 5 to 7 days, and make sure you're thinking about whether the frequency that you're going to be giving the drug is going to be on the regular medication prescription chart, as a stat medication, or as a PRN when required. We recommend about 45 to 50 minutes on this section. It really is sort of the bulk of the marks, and the one that'll be the most time consuming for you. The treatment summary section of the BNF is really good. If you came to our first session, we did a bit of a tutorial on sort of how to navigate the treatment summaries of the BNF. So you can sort of, you'll see through the questions that we'll show you later, you can use the question to work out which treatment summary you need to look at to find the answer.
So the adverse drug reaction section's only 8 questions. So it's one of the shorter questions, and each one is only 2 marks. So it's only really 8% of your total marks. It's quite a quick section, so you should probably really only be spending about 8 to 10 minutes on it. And that can sound quite short, but actually a lot of the questions, you obviously, because they're multiple choice, you can answer them really, really quickly. So you can catch up on a bit of time in this section and maybe go back to the prescribing section and do some of the ones that you'd flagged. There are 4 different types of adverse drug reaction questions. So they can ask you type A questions, which is just identifying the adverse reaction of a medicine. Type B questions are identifying the medication that's caused a particular adverse reaction. And type C questions, which you have to identify kind of a drug-drug interaction, which causes an adverse reaction. And type D is about managing adverse drug reactions. So those are the main kind of formats that they'll ask you questions on, and it is quite a quick section, as I say.
So searching for advanced adverse drug reactions in the BNF, there is an interactions section that you can see there. You can also, from an individual drug, have a look in the drug interaction section. Control find is your best friend for this whole exam, really. It saves you a lot of time rather than having to traipse through. So if you know you're checking the reaction between, say, an ACE inhibitor and a beta blocker, you can just type that in on control find, or you can use the interaction section. A lot of this exam is about making sure you can navigate the BNF quite confidently. So dedicate some time to practicing the questions in a time setting with your screen split sort of with the question paper on one side and the BNF open on the other, which is how I would recommend to have it in the exam, and just practice there searching for your answers. So we're going to start the timed questions now. As I said before, it'll work a little bit like a mock exam. There's 9 questions. It will give you 2 minutes per question, and then you can move on. We're not going to read them out. We're going to treat it sort of reflectively to an exam. So write down all of your answers, and then we'll go through it with you. So I'll just get the first question up and start timing now. Good luck, everyone, and we'll explain in a bit. Okay, and we'll move on to question 2 now. And we'll move on to question 3. And we'll move on to question 4. So you're coming up to halfway. And question 5. Okay, we're now moving on to the adverse drug reactions, and we're going to give you one question for each adverse drug reaction. Okay, and question B. And question type C. And final question, and then we'll go through the answers. Okay, so that's the end of your timed questions. Hopefully everybody found that useful. And if you have any questions after we've explained or anything else, please pop them in the Q&A. So we'll go through the answers and explanations now. So your first question was, a 42-year-old patient presents to ED acutely unwell. Blood test reveal an eGFR of 14, where their baseline is generally greater than 90, AKI3 and a potassium of 6.5. ECG is subsequently taken, which shows widespread tau-tented T waves. Which medication should be given in the immediate management of hyperkalemia that has the effect of stabilizing the myocardium? So the answer for this one, you could have one of two answers here. This is often the case in the PSA. There might be a couple of appropriate answers. So don't be put off if you come out of the exam and hear friends saying slightly different things. It could still be right. So if you look up hyperkalemia in the BNF, I'll show you on the next slide where you can find that. It gives you the options of calcium gluconate 10% or calcium chloride 10%. Then you go through and pop in the dose. So for calcium gluconate, the example we've sort of highlighted there, it's a 30 ml dose, an oral dose given stat, and it gives you the option to sign and date the prescription as well, which again you always have to do in practice. The key to this question was really reading what the question was asking for. The management of hyperkalemia, calcium gluconate and calcium chloride, actually their effect is to stabilize the myocardium and sort of protect the heart muscle rather than to lower the level of the potassium. So if the wording was slightly different, it might have been that you were choosing a different medication in the management of hyperkalemia. Someone asked in the chat, and I did answer in the chat, but just to highlight to everyone, you do have access to the treatment summaries in the BNF. These are part of the BNF, so you do have access to those. You just don't have access to things like the nice clinical summaries or anything sort of external to the BNF. So if you load up the fluid and electrolyte treatment summary in the BNF, you can control and find hyperkalemia. You can read here that it says, as our patient had 6.5, calls for urgent treatment. You should be given the normal ranges as well. So you would know that sort of over 5.5 is when you're getting to sort of high hyperkalemia. Our patient had 6.5, so we'd be urgently treating them. sorry, I just realised it's IV, not oral. Is that what people are asking in the chat? I'm seeing a lot of questions come up. It's IV. That's just a typing mistake. Sorry. So it's IV calcium chloride or calcium gluconate to protect from the myocardium. There is other treatments as part of hyperkalemia, as you can see there in the guideline. But like I said, you're giving the glucose to reduce the potassium concentration, and that's not what this this question was asking. So just get yourself familiar with particularly the fluid and electrolyte treatment summary, because this has quite a lot of information. Just to also highlight relating to this, a lot of questions may surround side effects of medications and specific electrolyte abnormalities. The electrolyte disturbances in the online BNF, which you have access to in the exam, will come up with just electrolyte disturbance as the side effect, but won't specify which of the electrolytes that the medication deranges. So a tip that I got when I was revising for this was that if you take in a paper copy of the BNF, you can use the index at the back, look at, say, hyperkalemia, hyponatremia, and it tells you which medications it's linked to. So that's a good sort of tip as to, I had the corner of my page folded over for the hyperkalemia, so that if a question asked if that was a side effect, not directly relating to this question, but just a kind of a tip generally relating to using the BNF.
Okay, so question 2 was a question about asthma prescribing. So 22-year-old presents to her GP for an asthma review. She reports using her salbutamol inhaler 4 to 6 times a week on average. Her asthma symptoms wake her at night weekly. She has missed work twice in the last month due to asthma symptoms. So her current medications, she's on a salbutamol inhaler and a Clenil inhaler, and she also takes Yasmin. So a couple of questions earlier in the session were about brand names of drugs. So I think that's particularly pertinent when you're talking about inhalers and contraceptives. If you type in the name of the inhaler or the contraceptive, it will come up because the name is in the medicinal forms section of the BNF. Normally in the exam, Yasmin would have after it a dose of estrogen and a dose of progesterone, so it kind of gives itself away. And the inhalers the route will be inhaled, so you'll know that it's an inhaler. I think most of us know Clenil is a low-dose steroid inhaler. And so she's on a SABA and an ICS. So we've been asked to prescribe an additional medication to control her asthma. And that's because obviously she's having these symptoms above. So she's using her SABA more than 4 times a week, and it's waking her at night. So we need to step up the ladder of her treatment. So there are a couple of options for this question. For the answers slide. Are you all right to move it on, Safe? Thanks. So the first option is to prescribe a long-acting beta agonist, so salmeterol or formoterol. So that's 1 puff inhaled twice a day, ongoing. So there's no real duration with these inhalers. This would be a long-term prescription. The other option is montelukast. So that's an oral tablet. So that's 10 milligrams orally at night, and that would also be ongoing. So the treatment summary that you need for this one is BNF treatment summary for chronic asthma, not acute asthma, because she's not having an attack. We're just managing her chronic symptoms. So it's useful if you want to get it up now while I talk it through it, because I'm going to go through what it kind of says. So the BNF treatment summary summarizes both the NICE guidelines and the BTS guidelines. My personal feeling would be that they'd give you the mark for either following the BTS ladder or the NICE ladder, because they're both referenced in the BNF, and that's the resource that they give you for the exam. So just going on to the next slide. The BNF goes through this ladder. So it's the intermittent reliever, the regular preventer, an initial add-on therapy, and then additional controller therapies. So the intermittent reliever would be a SABA inhaler, and then the regular preventer would be a low-dose ICS. So we know that our patient was already on both of those. So the initial add-on options are Lertra, a LABA, or a LABA and an ICS. So the additional controllers on top of that are a combination of the above options. So like a Lertra and a LABA, or alerta, and a LABA and an ICS. So a LABA and an ICS, just so there's no confusion, is also known as MART. So it's like maintenance and reliever therapy. There are other things that you can add on, so things like a LAMA or theophylline. So a quick review of how they all work, because I know it's lots and lots of kind of acronyms for asthma. The BAs, the ones that end in BA, are like bronchodilators. So a SABA works on the smooth muscle in the lungs. It targets the beta-2 receptors in the airways and activates them because it's an agonist, which helps relax the muscles in the airways. So a SABA will essentially last for about 3 to 6 hours. A LABA acts in the same way as a SABA, but the effects last a bit longer. So they last about 12 to 24 hours, and it takes a bit longer to feel the effects. A LAMA, sorry, I've got a cough. A LAMA is a muscarinic agonist, and they're bronchodilators as well. Ipratropium is a SAMA, so it's like the equivalent of the SABA, but for the MAs. So ipratropium is what you would give in acute asthma. You don't generally use short-acting muscarinic agonists for chronic asthma. And then tiotropium is an example of a LAMA that you could give as an additional controller therapy. And then the LTRAs is a leukotriene receptor antagonist. So that's an anti-inflammatory, and it's a bronchodilator, and it's the only one that's a tablet, not an inhaler. So the reason I didn't put a LABA and an ICS as an possible answer to the question, I only put like a LABA and an LTRA, is because the question asks, please prescribe an additional treatment, and a maintenance and reliever treatment, so a MART, would involve stopping her current low-dose steroid inhaler. So it kind of narrows down the options for you. In reality, you'd probably, in the real PSA, you'd probably get some marks for prescribing a MART in the exam, but it's the less obvious option when you look at what the question's actually asking you. So the next slide is just a summary table of all of that, and it includes the inhalers for peds as well. This is taken from my finals notes, and it summarizes the BTS sign guidelines. So the only real difference is that NICE suggests that you can use an LTRA in step 3 rather than step 4, but it follows the BNF steps quite nicely. So I hope that's useful for you guys.
There was also a question that I have answered in the chat just quickly, but the slides will be available to you if you fill out the feedback link at the end of this session when we send it, and then you'll get a copy of this recording and the slides, so you'll have access to this beautiful table. Ooh. Okay, so question 3, you're called to review a patient with reduced consciousness on the wards. You perform an A to A assessment, and the blood glucose is 2.7. Please prescribe appropriate IV therapy to treat this patient. Again, importance of reading the question here will become apparent. Just as a note for clinical practice, whenever someone has reduced consciousness, really good to just check the BM. It's such a quick bedside test, part of your A to E, and can often give you a quick sort of explanation. I had this very recently on my elderly ward. So the options here for an appropriate IV therapy for hypoglycemia are giving 10% glucose or dextrose. That dose is 200 mils stat and 20% glucose dextrose. The dose is 100 mil IV stat. A couple of things surrounding this kind of prescribing and relating to what the BNF says. You can give either of these two, and they have the same kind of efficacy. I know that 50% glucose is often kind of bandied about as an option for treatment, but it's generally not really used, and the nurses can't actually administer it without a doctor having already prescribed it and being there. So it's a hypertonic solution. It's quite irritant and it's quite viscous, so it's quite hard to give, whereas the 10% and the 20% glucose are sort of have an equal efficacy to giving 50%. In the BNF, it also does give you options for levels of consciousness for treating blood glucose. So if a patient's conscious, able to swallow, has a safe swallow, great to start on kind of the things like glucogel. Unfortunately, Lucozade has actually changed its ingredients due to the sugar tax. So now you actually can't use something like Lucozade to try and bring someone's BM up. But there's glucogel and other sort of gel tablets as an option. But generally, if a patient's unconscious or if it's resistant to this oral treatment, we give IV glucose. So as I said, you can give 10 to 20%. We pop stat in the indication, and someone has asked in the chat, I've seen that whether you need to write sort of the length of time for stat. Often it's good to write the length if you know it. So for the hyperkalemia question, you give calcium gluconate over about 2 to 5 minutes, and this is a medication that in practice you actually administer often, as often the nursing staff don't administer it. So for this, it's over about 15 minutes, the start dose. IM glucagon is an option. In practice, if a patient has IV access, you're going to give them IV glucose. It's a more reliable treatment, and it is kind of a bit of a better treatment, but you wouldn't be penalised, I imagine, in the PSA for putting IM glucagon as an answer. It's just in clinical practice, you probably wouldn't give it if the patient has IV access. Where IM glucagon kind of comes in to play a bit more is in the community, if obviously your patient doesn't have IV access and if their consciousness is reduced, so sort of oral solutions wouldn't be appropriate. The question did actually specify, though, in this case, what IV therapy. So really, we shouldn't have been putting IM glucagon as the option.
So question 4 is, a 56-year-old man is admitted to hospital. He smokes 40 cigarettes a day, but is currently too unwell to leave the ward. Nonetheless, the patient is feeling anxious and having strong cravings for a cigarette. Please prescribe a suitable regular medicine for this man to aid his symptoms of nicotine withdrawal. So the answer for this question was to prescribe this man a patch. So we can go on to this next slide. Thanks. So it's a nicotine patch, and the dose would be 21 milligrams over 24 hours or 25 milligrams over 16 hours. And the dose would be one patch, or you could put because I think you can put things like one application, one puff, one patch, or it would be equally correct to write 21 milligrams over 24 hours. The route is topical, and the frequency, sorry, that should have said one a day. And the duration would be ongoing. The difference between a 24-hour patch and a 16-hour patch is just that sometimes nicotine can keep people awake at night, and some patients prefer to have a patch that they take off for like 8 hours while they're asleep, and then they put it back on in the morning. So either one would be correct. So just going on to explain that. So the treatment summary that you're looking for in the BNF is called smoking cessation. And this is where it's just a kind of tactical thing for the exam, is like knowing the names of the treatment summaries that you're looking for. So prescribing nicotine replacement is kind of explained under that smoking cessation treatment summary. Nicotine patches is normally, as I said, on for 16 hours and then removed overnight. And then 24-hour patches can be given if they're not bothered, their sleep's not bothered by it, and if they have strong morning cravings. You can prescribe other things to help people with nicotine withdrawal, so like PRNs, like short-acting nicotines, so gum, lozenges and sprays when they get breakthrough cravings. So if someone smokes, this is all in the treatment summary, if someone smokes more than 10 cigarettes a day, then they need a high strength patch. So they need either the 21 milligrams in 24 hours or the 25 milligrams in 16 hours. If they smoke less than 10 cigarettes a day, then you'd prescribe them a medium strength patch. So you'd prescribe them a 14 milligrams in 24 hours or a 15 milligrams in 16 hours. There are low strength patches, but generally they're not appropriate to use in hospital because you'd mainly use them for patients that you were prescribing them patches in the community to help them stop smoking. So once they've weaned off the high patch or the medium patch, you put them on a low patch as a kind of step down to get them on no cigarettes at all. So in hospital, if someone's a current smoker, a high or a medium strength is the one that you'd want to use. So the tip for finding this is basically looking in the medicinal forms section. So the transdermal patches section of the BNF has like all the doses of the possible patches that you could use. And it's just process of elimination. So if you know that he smokes more than 10 cigarettes a day, I think he smoked like 40 in the question, then you know he needs a high strength patch. So you're looking for the patch with the most milligrams of nicotine per 24 hours or per 16 hours to prescribe him. The other tip for this is to read the question. So the question asks for a regular medication, which will exclude a short-acting gum, lozenge or spray because they're PRNs. There are other withdrawal aids that you can prescribe for smoking cessation. So things like varenicline, I think it's called, and bupropion. But they're generally prescribed like 1 to 2 weeks before someone stops smoking. So it wouldn't be appropriate in an inpatient setting to prescribe someone one of those options. So the question's just asking for a patch. This one's me as well, sorry. Question 5 is about a 78-year-old man being admitted to hospital after a witness fall. He suffered no head injury. He had a STEMI in October 2 years ago, osteoporosis, hypertension, type 2 diabetes, CKD4, so his creatinine clearance has been calculated for you, it's 11, and he has peripheral vascular disease. He's currently taking aspirin for the STEMI, atorvastatin, bisoprolol, calcios, which is just calcium, vitamin D, amlodipine, lisinopril, insulin, and dapagliflozin. And the question is asking you to prescribe appropriate VT prophylaxis for this patient. So the answer for this would be to give him heparin, unfractionated, 5,000 units, subcut BD, ongoing. So I thought this question might cause some confusion. So I'll just take a minute to explain. Just to clarify, this patient had a witness fall with no head injury. So we're not concerned about him having a bleed. The question makes no mention of him having any other injuries, and it doesn't mention any worrying red flags like a reduced GCS. He has no focal neurology or anything like that. So, so essentially, we're not worried about him being injured from this fall. It's still a medical patient who's expected to have reduced mobility during his admission, and so he needs VTE prophylaxis. The other thing that I thought you guys would ask some questions about is that he's on aspirin, which is an antiplatelet for his STEMI. So antiplatelets like aspirin and clopidogrel, etc., are prescribed after like MIs and strokes. They're not adequate VTE prophylaxis when you're an inpatient. So even if this patient had his MI last month and was on dual antiplatelet therapy, so even if he was on like clopi and aspirin, he would still need VTE prophylaxis because his risk of clot outweighs his risk of bleed. Whereas in comparison, if he was on a DOAC for like AF, or if he was on warfarin for a metallic heart valve or something, then we wouldn't anticoagulate him anymore because those anticoagulants are sufficient VTE prophylaxis, whereas antiplatelets aren't. So you still prescribe him like a low molecular weight heparin or like unfractionated heparin. So just summarising some of that in the next slide. Got a screenshot of the BNF treatment summary, which is called, I think it's called venous thromboembolism treatment, including in pregnancy. And then there's another one called venous thromboembolism prophylaxis in surgical and medical patients. So the medical patients bit, it says patients should either be given a low molecular weight heparin as a first line option or fondaparinux as an alternative for a minimum of 7 days, but really it's for their admission. Patients with renal impairment should be given either a low molecular weight heparin or unfractionated heparin, and the dose should be adjusted as necessary. So your options really, you have 4 options for VTE prophylaxis. You can give them no VTE prophylaxis, and as I said, that would be for someone who was already on a DOAC or was on warfarin, or a patient with a really high bleeding risk for whatever reason. And then you might offer them mechanical VTE prophylaxis, so like stockings or something. Low molecular weight heparin is generally what most patients are on. So it can be something like enoxaparin, 40 milligrams subcut once a day. If their eGFR is less than 30 or their weight is less than 50 kilograms, then you would halve that dose. So they should be on 20 milligrams once a day. And then if they weigh over 120 kilograms, you double the dose. So they get 40 BD. If their eGFR is less than 15, which if he has CKD4, it'll be less than 15, then you can give unfractionated heparin instead, which is 5,000 units BD, still subcut. You can give fondaparinux to some patients. Low molecular weight heparin is derived from pigs, so people with certain like dietary and religious requirements would rather be on like fondaparinux instead. Just a note for your future practice. So the three things that you need to be thinking about with VT prophylaxis is platelets, renal function, and weight. And then once you've considered all three of those things and the patient's bleeding risk, you'll know which of the four options you should prescribe. I hope that makes sense.
Okay, so we're now moving on to the adverse drug reaction section of the questions, and we gave you one for each of the sort of type of question. So this first question is: a 41-year-old female presents to her GP for her annual asthma review. She has a past medical history of asthma, hypertension, and inflammatory joint pain. Her asthma is well controlled on salbutamol, PRN, inhalers, and regular clinolmodulate BD. Her GP notices, however, she's on a medication that is contraindicated in asthmatics. Which of the following medications would be contraindicated? So the answer for this question is naproxen, and I'll explain why on the next slide. So this question there's a couple of elements to it. It gives you the hint of what the medication might be, given her past medical history, as often inflammatory back pain is treated with things like naproxen. She also has hypertension, but the antihypertensives that we'd listed there, if I go back, are safe in asthma. So you can give ramipril absolutely fine in asthma, and it's not in sort of the adverse reactions. Prescribing in asthma and COPD does need caution. Often it's because medications can induce bronchospasm, which we want to avoid in people whose airways are already slightly narrowed, who are struggling, although her control is good. There's sometimes some contention with whether these medications need to be completely avoided and are completely contraindicated, or whether actually in an asthmatic whose asthma is well controlled and they haven't had an adverse reaction to the medication in the past, whether this can kind of be given. So you will see in practice some people with asthma on, say, beta blockers, but for the purposes of the PSA and for the purposes of sort of an adverse drug reaction question, don't give anything if it's a sort of adverse reaction. So if you look in the BNF and search in naproxen, you'll see that it's contraindicated in asthma, can worsen asthma and cause bronchospasm, as I said. Some other common medications to sort of be aware of in asthmatics that can cause bronchospasm, beta blockers again, and adenosine is actually contraindicated in the BNF. So you'd use verapamil as an alternative there, rather than giving adenosine. I can also see someone's raised their hand. If you have a question, could you just pop it in the Q&A one, because I don't know how else we'll hear your question. So if you can pop it in the Q&A, that would be great. So a type B question, identifying the medication causing the adverse reaction. So this question was: a 25-year-old who's 11 weeks pregnant presents to her GP with dysuria and frequency. Urine dip is positive for a urinary tract infection. Which of the following commonly prescribed antibiotics for a UTI is contraindicated in pregnancy due to its teratogenic effect? Your options there are nitrofurantoin, amoxicillin, trimethoprim, cephalexin, or doxycycline. Again, really helpful to read the question. Questions can sometimes give you a hint as to what the answer is going to be. So the answer here, sorry, I don't know why that's covered over, but the answer here is trimethoprim. This lady's 11 weeks pregnant, which still falls into the first trimester. And if you pop in trimethoprim and look under pregnancy, you can see that it's teratogenic in the first trimester because it's a folate antagonist, which we don't want. We generally want women to have a lot of folic acid in pregnancy. So we avoid this in the first trimester. Interestingly, it is present in milk, but isn't known to be harmful in breastfeeding. So with antibiotics and pregnancy, it's not a blanket rule. It's often sort of at specific points of the pregnancy will be contraindicated. So I've just done a little breakdown here of the reason that trimethoprim is the answer and whether the other medications are teratogenic and when they should be avoided. So nitrofurantoin is a teratogenic medication that should, that's avoided in, yeah, so it should be avoided in term pregnancy, but this lady's only 11 weeks. So at this point, she can safely use nitrofurantoin, but in term pregnancy and breastfeeding, there's a risk of neonatal hemolysis. So quite useful that nitrofurantoin and trimethoprim, as the sort of quite common antibiotics prescribed in UTI, can be given at different points in pregnancy cycle. Amoxicillin isn't known to be harmful in pregnancy. This woman's nothing mentioned about a penicillin allergy, which is always one to be aware of, particularly with antibiotics, but with any medication, is to check allergy status, because they often will sort of sneak that in there in the question, and then it'll be using different indicated medications. We've already discussed trimethoprim being risk in the first trimester due to being a folate antagonist. So that was the correct answer for this lady at 11 weeks. Cephalexin, again, like amoxicillin, isn't known to be harmful in pregnancy. You can find this in the pregnancy section of each of these individual medications. And doxycycline, again, we should avoid in pregnancy and breastfeeding. It can discolor the teeth, giving a yellowing of the teeth and affect skeletal development. But this isn't a first-line antibiotic for a UTI. So while it would be contraindicated in this lady at 11 weeks, it wouldn't be an antibiotic that we'd be commonly prescribing and looking to give. So that's why that's the answer.
So question C is asking about a drug-drug interaction. So the 34-year-old lady started on a contraceptive by her GP. Despite taking the contraception as instructed, she gets pregnant. The contraceptive her GP prescribed was a tablet called Yasmin. So there we go with the estrogen and the progesterone dose. Which one of the patient's medications is likely to have led to her contraceptive failure? So isotretinoin, zolmitriptan, sertraline, carbamazepine, or lansoprazole. So the answer for this question was carbamazepine. And that is because it is a CYP 450 inducer. So if we go on to the next slide, so it will decrease the efficacy of your contraceptive pill because they're both metabolized in that pathway, and it's an inducer, so it will speed up the rate of metabolism of the pill. Just going through them all then, isotretinoin, that is a medication given for severe acne when other treatment methods have failed, and it's not known to interact with the pill. So actually being on contraception is a mandatory requirement when you start taking isotretinoin, because isotretinoin is very teratogenic, so they want to make sure that you definitely don't get pregnant when you're on that. Zolmitriptan, so the combined contraceptive pill might increase your exposure to zolmitriptan, so you might get more side effects from the triptan, but it's not known to reduce the efficacy of the pill. Sertraline isn't known to interact with the pill, and neither is lansoprazole, so carbamazepine was the answer for this one. And then just going on to question D. So an 82-year-old presents to A&E after being found on the floor at home. They're newly confused. A CT head reveals a large subdural bleed. So their past medical history is significant for AF, and they've had 3 previous TIAs, celiac disease and osteoarthritis. So their medications, they're on dabigatran and paracetamol. Which of the following medications should be prescribed for this patient as a once only? So it's 1 tranexamic acid, 2 idarucizumab, 3 adenexate alpha, 4 phytomenadione, and 5 alteplase. So this question is kind of like, I'm trying to give you an example of how to like use exam tactics. So a lot of those medications aren't ones that we come across every day. So their names are not familiar to us, and it's kind of just teaching you, like, don't panic if you see a list of medications where multiple ones you aren't sure what they are, especially for an adverse drug reaction question, because they're generally quite quick, so you do have time to go through the list and rule things out that you know aren't correct, and then like BNF the names of the ones that you're not sure about. So if you quickly BNF'd the names of these drugs, if we go on to the next slide, the answer is idarucizumab. So you can't possibly know every medication in the world. The PSA is a very time-pressured exam, but the ones you don't know, you have very good time to quickly type in and review their indications for an SBA sort of type question. So idarucizumab, if you typed it in, the BNF says it's a monoclonal antibody which can be used to reverse the bigatran. So this guy's got a bleed and he's taking a DOAC. So it'd be good to reverse that. Tranexamic acid can be used to treat life-threatening bleeds, but it's less specific to the medication that this guy's being used. So for a single best answer question, answer 2 is more appropriate. Adenexate alpha is recombinant factor 10A, which can reverse apixaban or rivaroxaban, but the bigatran has its own reversal agent. Phytomenadione is just vitamin K, and you can use that as a reversal agent for warfarin. He's not on warfarin. And then alteplase is a thrombolytic that you use to dissolve clots in ischemic stroke, and so you obviously shouldn't give it if someone's having an acute bleed. So that one's wrong. So the answer's 2. I hope that makes sense. We've just got a couple of other really quick slides before we go on to answer some of your questions. So a couple of common adverse drug reactions that they test in the PSA are electrolyte derangements. So like a low potassium on a diuretic or a low sodium on a diuretic. Other drugs that cause low sodium are things like carbamazepine, PPIs, SSRIs, and antipsychotics. We were just talking earlier before we started about how sometimes on the side effects section of medications on the BNF online, it just says electrolyte derangement, and it doesn't say specifically hypokalemia or hyponatremia. And that's when it's good to have a paper copy of the BNF in the exam, because there's like a page in the back that has a list of all the electrolyte derangements. I'm right in saying that, aren't I, Sophie? That exists.
Yeah, so it's in the index. When you look up sort of say hyperkalemia was a sort of particular one that often comes up. Someone did ask in the chat, and I have answered it, but just for the purpose of the whole group, our med school didn't provide paper BNFs. You get obviously access to the online BNF, but if you want to take one, you do have to bring your own. So maybe see if you can borrow one from a placement, borrow one from a friend, borrow one from an order year, or if you did want to buy one, they're quite expensive, but yeah.
I think it would even be fine if you could get your hands on a copy from a couple of years ago, because
yeah, it doesn't have to be an up-to-date.
Electrolyte won't have changed at all. Antimuscarinic drugs, so they cause things like urinary retention, drowsiness, dry mouth, and that's an adverse drug reaction that's commonly tested. And another one just off the top of our heads earlier was just deranged LFTs and statins. So some common interactions that can be tested are things like methotrexate and trimethoprim. They're both antifolates, so they can cause bone marrow suppression. And just in case you didn't know, cotrimoxazole has trimethoprim in it. Cotrimoxazole is Septrin, it's like an antibiotic. And so yeah, that's why cotrimoxazole also interacts with methotrexate. Warfarin interacts with like literally everything, so they test that all the time. And ACE inhibitors and spironolactone also interact with each other with the potassium. That on the right is just a list of the kind of CYP 450 inducers and inhibitors. So SCRAP-GP is just an acronym for the drugs that are inducers, and then sickfaces.com is an acronym for the ones that are inhibitors. So that's just quite useful if you need something to help you remember, because it's quite a long list of drugs to keep in your head. And then the management ones that they test are things like anaphylaxis, so know how to prescribe IM adrenaline, hypoglycemia, so we just talked through how you treat hypoglycemia, and diuretic-induced dehydration, so know how to prescribe fluids, or which fluid would be appropriate if someone was like mildly dehydrated, and which would be if they were like low blood pressure, high heart rate sort of thing. And then over anticoagulation, so with a DOAC, we've talked about how to reverse some of the DOACs, and with warfarin, you can like reverse warfarin with either oral or IV vitamin K, depending on how severe the over warfarinization is, so how high their INR is.
Okay, so thank you everyone for coming today. We've popped the feedback link in the chat. Can everyone see that? Just want my Q&A if that's working. There is a few questions in the chat. We've tried to answer a couple as we go through, but we'll have a look through now in the chat and answer any questions that we haven't answered yet. But please fill out the feedback form. It's really useful, and when you guys are F1s, you'll be bombarded with portfolio things. We have our final PSA session next week on the final 2 sections, and Katie's doing her wonderful neurology session this week, and then ongoing until June every week is the countdown to finals kind of sessions, so you can tune into all of those, get the Facebook events, get your reminders, and save the dates. So we'll start having a look through the chat now. There's been quite a few questions relating to accessing the slides from previous sessions. We've had extensive discussions about this as a committee, and completely understand that it's a time commitment and people are busy and won't be able to attend every session, but as a kind of rule, we are giving sort of the recordings and the slides to just the people who've attended and filled out the feedback, partly as motivation for F1s to come and teach it so they can put it in their portfolio, and partly because then we would kind of be giving our resources sort of away. So I hope everyone understands that. But if there is any exceptional circumstances or anything, please do feel free to message us and we can have a look at that.
There's a couple of questions about working out the volume for the glucose hypoglycemia question. I just thought I'd answer that one live because there's quite a few people have asked about it. So essentially, I don't know if we've already had the drug calculations PSA session yet, have we? I think it was last week, the calculation.
Yes, yeah.
But when you have a fluid that's like a percentage, so 10% glucose, the glucose quantity in that fluid is 10 grams in 100 mils. And so do you mind skimming back to the glucose question, Sophie? Is that okay? So if someone is hypoglycemic and needs IV glucose replacement, then the BNF says that the dose of glucose that you need to give them is like 15 to 20 grams. So if you've got a 10% solution of glucose, there's 10 grams in 100 mils. So there's 20 grams in 200 mils. So you'd give 200 mils of 10% glucose over 15 minutes. And if you were going to give 20% glucose, then you'd just halve that. So it would be 100 mils of 20% glucose, because there's 20 grams of glucose in 100 mils of 20%. Does that make sense? I'm sorry, I can't like scribble it out, but the maths is like basically just 10% is 10 grams in 100 mils. So you want 20 grams. So that's that one.
Following on from that, there's been a couple about putting stat as the rate. Generally, say it's sort of the time, just so there's no contention over what stat kind of means, because that can be open to interpretation. So yeah, reasonable to say sort of over 15 minutes, or for the sort of say calcium gluconate over 2 to 5 minutes for hyperkalemia treatment. We'll just keep having a look.
If someone's asking about the nicotine replacement therapy one, so yeah, when you search the drug nicotine and you go on the BNF, you go down to medicinal forms. Let me just do it while I'm with you, so I'm not like lying to you about anything. So nicotine, and then you go on to medicinal forms, transdermal patch, and then it says all the different types of patches that you can possibly give someone. So something called Boots Nick Assist Translucent is a 25 milligrams and 16-hour patch. That's a high dose patch. And then you can find ones that are 10 milligrams in 16 hours, and they all have a brand name, but you're just looking at the dose, and that's in the medicinal forms transdermal patches section. Someone else has said that they managed to get a BNF from their local pharmacy that they weren't using. So that's a really good tip for anyone that needs one.
Is the feedback link coming up in the chat? I've just seen another question about that. The feedback link's in the chat for that person. A question, would you put TDS or 3 times daily? TDS is fine. That is a frequency, and that's what you'd put in real life. It generally is like the PSA is generally a drop down. If you do the practice exams, you can sort of see from that what it's reflective of in the exam.
So I don't know if I clarified the nicotine thing. There's still some questions about it. So people are saying it just says the price, but it also says, when I'm looking at it, it says active ingredients, and then it says nicotine 21 milligrams per 24 hours. And so essentially you're just looking for like the highest possible dose. I don't know if you're looking at it on your phone or in a book, but like on the BNF NICE website, I can see the transdermal patch, and then the first one on there is nicotine 7 milligram patches. And it says, and when you click show, it says nicotine 7 milligrams per 24 hours. And they all do. When you click show, you can see what the dose is.
There's a couple of questions as well about, I'll just go back to the start, because I think a couple of people might have missed just the way that the sections are sort of broken down. So I'll just go back to these. So there's 8 sections. It's a 2-hour exam. So the 2 sections that we've talked about today, the prescribing section is the biggest section. So we'd say spending the majority of your time on that because it's 40%. So about 40 to 50 minutes, which again equates to about 40%. If you work out how many marks each section's worth, and then almost give it that allotted amount of time, giving prescribing a little bit more. And for adverse drug reactions, as we've said, it's quite a sort of it's quite a snappy section that you can sort of use control find. So as Katie said before, about 8 to 10 minutes is sort of good for this, about 16 marks. So you're generally for the PSA looking at 2 marks a minute roughly, which is why the prescribing section's bulked up, because it's 10 marks.
I'm just skimming through, seeing if there's anything we haven't answered yet. The type D questions, what technique would you use? Would you search every drug singularly? So the type D questions, they're the ones where you're treating an adverse drug reaction, aren't they?
Yeah.
So, I mean, the question, you might know the answer just from like finals revision. So you might not need to search every drug singularly. And you might know quite a lot of the drugs in the 5 options anyway, so you might be able to rule some of them out straight away. What I'm saying though is that like if you don't recognize the name of a medication in any question, then just search it, because it kind of just, I mean, you can't answer it if you don't know what all the options are. So just quickly searching it allows you to answer it, or you can flag it, and then if you have some time left at the end, then take your time over like searching for the answers. Why does it say that idursulfase should be prescribed once only? Yeah, I mean, if you give it once, you'd only give it once first, and then if that kind of like reversed the effect, you can give it twice. I guess it kind of depends on the patient's dose as well.
You don't want to overdo the correction dose as well. It's a sort of managing act between bleeding and clotting, isn't it? So giving it as a sort of once time medication is sort of more appropriate for that, and then you can reassess clinically and things. If anyone, I'm looking through and I think most of these have been answered, but if I'm wrong, please do correct me. Oh, there is one about if a patient's drowsy, is it classed as having a safe swallow? I think for the purposes of this, I wouldn't be giving anyone who is drowsy oral glucogel, particularly when a majority of patients do have IV access in hospital. I think if they're drowsy, you are running a kind of aspiration risk, and for quite a quick correction and for the efficacy of kind of IV glucose, I would give that. And then for generally, like for assessing safe swallow and things, it's more complex, but for something acute such as the hypoglycemia, I would just avoid giving oral in anyone who's drowsy or reduced consciousness, because they're probably not going to be able to take it orally. Okay, so I believe that the answer to the question about does everyone sit the same exam is there is multiple exams, but I think if you're in the same sitting, you sit the same exam, is my understanding. But that's one to double check with sort of the PSA website. I also wouldn't stress too much about, there is sort of always a paper A and a paper B, but the pass mark is adjusted accordingly. So one paper's pass mark might be 60 and one might be slightly higher if it was deemed as a more manageable paper. So I wouldn't worry too much about that.
There's one question about could you use rivaroxaban? I think it's referring to the VT prophylaxis question, because they've given an indication in the BNF as prophylaxis of atherothrombotic events in patients with coronary arteries or symptomatic peripheral artery disease. Generally for VT prophylaxis, we only give low molecular weight heparin, unfractionated heparin, or fondaparinux, or mechanical prophylaxis. DOACs aren't really used for VT prophylaxis within patients. If you use the treatment summary, venous thromboembolism, I think it's what it's called, and then you go to venous thromboembolism prophylaxis, you can find medical patients or surgical patients, and it will tell you there which ones that you can use for VT prophylaxis within patients. Yeah, I think that answers the question. I think, has any more come through?
I don't think so.
No. How and when do you prescribe stockings? So you'd prescribe stockings if someone had a really high bleeding risk, and you didn't want to anticoagulate them anymore. I'm not sure that would really come up in the PSA.
I'd never seen.
I think like in real life, if you're doing paper prescribing, there's always a section for VT prophylaxis on the chart, and you can cross out the drug boxes and you can like circle stockings or something. But I don't think that they would test you prescribing stockings in the exam when there's so many other things they could test you on.
Hyperkalemia answer. I'll quickly. If you fill in the feedback form as well, you will get a copy of this recording and of the slides. So for any unanswered questions, but I'll just quickly pop that one on there, and then we'll let you all have a nice rest of your evening. Thank you for coming. Tell your friends about us. If you found this useful, do please fill in the feedback link. I know your PSA is coming up on the 3rd, isn't it? So this is the last PSA session I'm running before. Good luck with the PSA.
And I'll see you on Thursday and next Tuesday.
Katie's doing all of her sessions at once.
Out in January.
Thank you, everyone. I'm going to end this now.
Okay.